And today we are joined by Dr. Spivack, and we are going to be learning about oral health care and developmental disabilities. So Dr. Spivack is currently a professor in the Department of Pediatric Dentistry and leads the Special Care Treatment Center at the Rutgers School of Dental Medicine. A 1991 graduate of the University of Maryland Dental School, Dr. Spivack completed a general practice residency at St. Barnabas Hospital in Bronx, New York, and was senior fellow in special care dentistry at Helen Hayes Hospital in New York. Dr. Spivack is primarily a practicing dentist who has devoted his career to providing dental care to the population of adults and children with developmental and other disabilities, as well as the complex geriatric population. As an educator, he has published numerous papers and book chapters in the field of special care dentistry and has lectured extensively across the United States. Additionally, he has served as a consultant to multiple committees, including the National Council on Disabilities, which resulted in a revamping of recommendations relating to dental school educational goals in caring for those with special healthcare needs. He is an active member of the Academy of General Dentistry, AGD, where he served as regional editor of their award-winning journal before becoming president of the New Jersey chapter of the organization. He is also an active member and past board member of the American Academy of Developmental Medicine and Dentistry. Dr. Spivack's educational and patient care efforts have resulted in his being named a finalist for the Rutgers Masters Educators Guild Award in 2014. He is proud to have been named the ARC of New Jersey Healthcare Professional of the Year in 2015. Thank you so much for being here, and I'm very excited to hear more about this topic. I'm going to turn it over to you.
Thank you very much. I really appreciate it, Erin. That introduction pretty much says everything, so it knocks out my second slide entirely. But I'm really glad that we're having the opportunity to spend some time talking about oral health care because, as you're going to see, it really is a critically important aspect of healthcare overall, not just for individuals with developmental disabilities, but really for the population at large. So it's something that really does need to be discussed, and I'm glad it's getting a little bit of play here. So I've been at the Rutgers School of Dental Medicine for the last 24 years, pretty much, back when we were UMDNJ. So I go back to that point in time. So I've been here, and before that, I spent time at St. Joseph's Hospital, and prior to that, I was working as a dentist in New York in a whole bunch of different types of practice settings, between nursing facilities, between dental schools, private practice, and working in other developmental disability type settings as well. So I've had a lot of experience dealing with a really broad variety of patients. And I think that one of the things that really, when we think about patient care and we think about oral health care for patients, is that it really affects everybody, and it affects everybody in the same way to a very real extent. It's just how we kind of translate that knowledge and how we put that knowledge to use. And hopefully that's kind of what we're going to get to a little bit today. So just to start off, I have no financial disclosures, conflicts of interest, or sponsorships of any kind. Towards the end of our presentation this afternoon, I am going to be mentioning a couple of products that are things that I use and kind of recommend to patients when they come in for care. But there are analogs of those that are honestly just as good that you can use as well. And again, I have no sponsorships or conflicts of interest with those companies at all. So, just to start off with something that is very well known to pretty much all of you, I'm sure, approximately 23% of the population at large has a disability. And that number, to people who are not in the disability community or engaged at all with the disability community, for many of those people, that number really shocks them. It's a very large number. And that number includes people who have, issues with sensory concerns, whether they're blind, whether they're hard of hearing, whether they have problems with walking or things along those lines, whether there are difficulties with speaking. So disabilities, written in a very large, broad spectrum, accounts for about 23% of the population. About 3 to 5% of the population, depending on the studies that you read, have a developmental disability. And while 3 to 5% may not sound like a whole heck of a lot, the truth of the matter is that's a very large percentage of people. And while it sometimes may appear to be somewhat invisible, it's not. And especially in this day and age, it's becoming less and less invisible, which is a very good thing. And it leads to more discussions like this and to other discussions. So this is a good thing. So that this is something that does need to kind of keep up. Um, Access to oral health care has been an issue for a very, very long time. I've been a dentist for about 34 years now. And while the population of patients that I treat has stayed the same in terms of being a patient population with developmental and non-developmental disabilities, the population itself has kind of changed in terms of the aspects of the population. One thing that has not changed at all is the concern over access to oral health care. And this has been a very, very, very big problem. It's affected life and death. For many people, it's certainly affected the morbidity and mortality of my patient population and the population of patients, that I don't know who do need the care. Oral health care needs are the second leading health condition affecting the quality of life in the disabled population. And that really says something. When you stop and think about all of the potential needs that a person has as far as health needs, certainly within the disability population, and stop and think that the oral health needs are ranked number two there, that really says a lot. That really says a lot, and it really speaks to how important this topic is. One out of every two individuals with a disability cannot find appropriate health care. And, you would think that this is something that should have been addressed long ago, that should not be an issue, but it is. And it's a very, very real issue. Here in New Jersey, we probably have better resources to care for people with as far with their oral health care than probably in just about any other state in the United States. But the reality is, here too, the needs are extraordinary, and the access to healthcare, honestly, is much, much more limited than I or anybody else would really, really want it to be. And just to kind of point out what the problem really is, those with a disability are less likely to have seen a dentist in the past year than those without a disability. So again, that kind of brings it up to everybody and says, hey, look, this is a problem and something that we need to fight to face. It's something where the need for advocacy is extraordinarily important. The need for activism within politics is extraordinarily important. The need to make our voices known about it is really, really important too. So why is oral health care really important? Why do we care? Why is it such a big deal? Well, the mouth is really just the gateway to the rest of the body, if you stop and think about it. And, to a certain extent, we do ourselves a disservice when we separate the mouth from everything else. We look at medical care and then we look at dental care as something really, really separate from that. And that's not really the way it should be. I mean, dental care really is part of overall medical and overall systemic health. In fact, if we take a look at some of the big, big issues in medical care and medical health, we see that the mouth really is an important part. We can look at diabetes, respiratory concerns, cardiac concerns, and neurologic issues. All of these affect the population at large. All of these affect very, very specifically the developmental disability population as well. And so we're just going to go into this and spend a few minutes looking at it. So diabetes is perhaps the most well-studied, it's the most direct, it's the most, in a lot of ways, the most obvious sort of situation that we can deal with here. If a person has periodontal disease, if the gums are bad, if the teeth are really, really bad, if there's a lot of bacteria in the mouth, well, what happens is that bacteria is going to get into the systemic, into the body system. It's going to get into the blood system. It's going to travel throughout the body. Eventually, what it's going to do is it's going to affect glycemic control. So the patient's blood sugar is going to get much worse if the periodontal health is bad. On the other hand, if periodontal health is good, it's really going to help to improve the patient's glycemic control. So on the one hand, periodontal disease absolutely affects an individual's glycemic control. Now, the other thing that's really important is this is a two-way street. So glycemic control is going to affect your periodontal health too. If you as a diabetic individual can control your blood sugar, can keep everything under good control, that's going to improve your periodontal health and your overall oral health. So this is a big deal. This is a big deal. And this two-way street is something that's been studied for quite a long time. It's a very, very well-known um, issue within dentistry and medicine, and it's well known how these two affect each other. When we look at respiratory issues are probably far and away the biggest issue medically that really does affect the disability population for lots of reasons. And we take a look at the relationship between periodontal health and the overall respiratory health of individuals. Well, this kind of seems like a no-brainer, right? This is sort of thing that you would think, well, this is a very, very obvious point. It hardly requires one to even think about doing a study for it, right? If your mouth is full of bacteria, if your mouth is full of plaque and calculus, which basically is nothing more than hardened bacteria, what happens to that bacteria when you chew, when you eat, when you brush your teeth? What happens if your gums are bleeding because the gums are really, really in bad shape? What happens to all that bacteria? Well, it enters into the bloodstream, certainly. But also that bacteria, all that plaque, it's going to be aspirated back. It's going to be breathed back into the lungs. And that's going to set up an aspiration pneumonia type situation. Um, Pneumonia, aspiration pneumonia, is one of the leading causes of death for individuals broadly, and certainly individuals within the developmental disability population. Our job in dentistry, when we clean teeth, is not just to clean teeth. You know, it's not that cleaning teeth is like cleaning windows or cleaning floors. But the reality is that when we're going ahead and making sure that the mouth is healthy, if the mouth is clean, we're really, really affecting the health and the eventual lifespan of individuals as well. It's really a life and death issue, and this slide really demonstrates that. Cardiac conditions are a little bit more of a stretch, I guess, when you want to go ahead and look at it in terms of how well do we really understand the relationship between the mouth and cardiac issues. But again, this has also been studied for a good number of years. If we go back to the mid 1990s, this is when a lot of this research really first came to the fore and really first started to make news outside of the dental community, outside of the medical community. People start to realize this just even broadly when you pick up a newspaper or watch the local news. Periodontal pathogens, bacteria in the mouth, they will lead to inflammation again as it gets into the bloodstream. That inflammation will lead eventually to potential stroke, heart attack, and endocarditis for patients. In fact, we're aware that for individuals who have heart murmurs of a certain type, for many, many, many years, we've been aware that those individuals, prior to having dental treatment, are going to need antibiotics in order to keep them safe from endocarditis, which is a condition that can kill you. So it's something very, very serious. It's a very, very real concern that we have here. And understanding this is really important. Understanding again how, if you are someone with a cardiac condition, how important it is to keep the mouth healthy. This is something that you have to know. And this is something that you have to take very, very seriously. Now, this last point here on the medical side, when we talk about neurologic concerns, and we talk about the relationship of those neurologic concerns to oral and systemic health, this is a big deal, and this is something that has come to light much more recently, and it's received a lot more press recently and a lot more research recently. We're aware that periodontal disease, gum disease, is going to lead to tooth loss. If you've got teeth and the teeth are starting to get loose, it's kind of like a post in the ground, right? If that post has lots of dirt around it to keep it nice and secure and strong, that post is going to be strong. If the tooth has lots of bone around it, it's going to be nice and strong. It's going to stay in the mouth, it's going to be healthy, it's going to function well, and it's going to feel good. As you start to get periodontal disease and the gums weaken and the bone weakens, those teeth begin to move much more so. When those teeth start to move, eventually those teeth are going to be lost. Either they'll come out by themselves or they'll have to be removed, professionally. What's come to light through many studies, and it's been a large number of studies, and pretty much they very much agree on a lot of points, is that this amount of tooth loss and periodontal disease eventually is tied in and linked to dementia and a cognitive decline as well. So again, we can look at all of these medical complications, and we can see that the mouth really affects far more than just our smile and just our ability to eat. It actually affects overall life here. So this conversation that we're having today, and the conversation that hopefully you're going to have with other people and people who are either you're caring for or you're caring with or you're caring about, it's going to be something that it continues as well. So when we talk about dentistry, there are three common oral diseases that we as dentists deal with. Broadly spoken, they're periodontal disease or gum disease. There are dental caries or cavities, it's more commonly known, and there are oral cancers as well. Now, of these three situations, when we deal with oral cancer is far less of a concern, thankfully, than the other two because oral cancer kills. And oral cancer kills a lot of people, and it kills people relatively quickly. One of the problems with oral cancer is that by the time it's generally picked up, very often it's too late to really do much about it, except for very, very radical measures of radical surgeries, radical radiation and chemotherapies. And quite often, honestly, the condition is caught too late to do much for. Oral cancer, however, is not really as much of a risk in the developmental disability population as it would be in other populations, primarily because one of the large causes of oral cancer is smoking and drinking, alcohol use. And so within our population, the population that I see, that's much, much less of a concern. So again, we see far, far less oral cancer. We don't see no oral cancer. And the need to follow up with a dentist on a regular basis, at least once a year, even twice, or maybe sometimes even 3 to 4 times a year, really, really is critical, and that should highlight this. Dental caries and periodontal disease, on the other hand, are big issues. And these are things that are going to affect a person's life. They're going to affect a person's health. They're going to affect comfort. They're going to affect function. And they're going to affect looks all the way throughout the lifespan. And these are things that we do need to deal with. So what causes most dental disease? When we're talking about cavities or dental caries, when we're talking about periodontal or gum disease, what causes most dental disease? Well, the answer is, quite frankly, if you want to take it back to its most basic cause, it's basically oral hygiene. Is a person able to go ahead and keep the mouth clean? Is the mouth staying clean? Is the mouth staying healthy? If it is, again, that's going to go a long way towards making things pretty good. If not, again, things are going to go bad pretty quickly. So, why is oral hygiene a challenge in the first place? And this is a very, very complex question. It's a very multifactorial sort of issue, and we need to look at a lot of different answers if we're going to kind of figure out how we're going to answer this question a bit more broadly. We can look at physical disabilities, intellectual disabilities, but we have to look also at the patient-specific anatomy and physiology. We have to look at what medications the individual is taking, and we have to look at the diet that a person is on as well. So I want to spend a little bit of time kind of going into these issues and, as we discuss them, think about how they affect the people that you're with, that you're caring about, and how they might affect you as well. So first of all, physical disability. To a lot of respects, this is, again, really, really the most obvious sort of issue, right? If a person has significant contractures of the limbs, if a person has an inability to use their arms or their hands, if the hands or the arms aren't able to function or aren't able to be functional because of, the lack of digits or the lack of a hand or something like that, well, clearly you can't brush your teeth effectively. I'm left-handed. I brush my teeth with my left hand. If I were to break my left hand, my left arm, now I have to brush my teeth with my right hand. I'm not going to do as good of a job because I'm very, very left-handed. So again, losing the ability to use an arm can be very, very impactful for an individual. So we need to think about physical disability just from the perspective of what exactly is it that we're actually seeing? What's going on that we can actually see? Physical disability obviously extends well beyond just the hand in terms of our ability to brush the teeth and maintain the teeth, right? If a person has significant contractures of the arms and the legs, if they're significantly frail, we look at the picture of the patient on the individual on the left-hand side. Well, we see how thin that individual is. We see how contracted the arms are, how thin the arms and the legs are. It's much, much more easy to have bone breakage in a case like this for the individual being moved from a dental chair to a wheelchair or to a stretcher and back and forth again. If the person is going to require any supporting person to help to hold them while the care is being given again, that's going to be much more difficult. For this individual to get to a dental visit is also going to be much more difficult. We obviously think about the issue of transportation in terms of can a person actually get to a dental appointment, right? Can you get up the stairs into the dental office if there's even one or two stairs? Can you make it up onto the sidewalk? How do you get up and down the stairs from an apartment building if you live in an apartment building and you're in a wheelchair and you have an inability to make it down those stairs easily, right? All of these things are challenges that we as dentists have to face when we're dealing with our patient population because if you can't get here, I can't treat you. And also, these are the challenges that you have to face and think about when you're thinking about your own oral health and other health cares as well. Also, the position that a person is. If we look at the patient on the right-hand side, the individual on the right-hand side, we see the way his head is placed. That's going to make it much, much more difficult to clean the teeth. It's going to also make it much more difficult for me as a dentist to get into the mouth to do a professional cleaning for the patient as well, right? So we really need to think about all of these factors. Can either of these individuals transfer from a wheelchair into a dental chair? Well, maybe yes, maybe no. Um, do the wheelchairs actually recline back? Do they have that tilt function? Again, sometimes yes, sometimes no. So we have to think about all of these things when we're thinking about dealing with a patient in terms of how their oral hygiene, their health care is. And this is going to affect a person's ability to care for their mouths or to have other people help care for them. Now, intellectual disability is its own separate challenge, separate from the physical disabilities. We can go ahead and we can take a look at this chart here that I have a picture of. And this chart is broken down into 15 different steps, right? And these are the steps involved with brushing teeth. If you actually go ahead and look at a couple of other breakdowns of the way you brush teeth, it actually can go up to about 26 steps in terms of brushing your teeth. Get it going from the point where you actually pick up the toothbrush, pick up the toothpaste, unscrew the cap, and so on and so forth. It's not a simple, obvious, straightforward thing for everybody to do, and it can be a very, very difficult thing for people to do. And not just those with developmental disabilities. We deal with individuals with dementia all the time, and again, it's the same kind of thing. Is there the ability to really, really get this done, not just physically, but from an intellectual and cognitive perspective? How difficult is it going to be to go ahead and accomplish these tasks? If they can't be accomplished easily, again, this is going to lead to a problem with the oral hygiene that eventually is going to kind of snowball and make the oral health much, much worse. And as far as intellectual disability is concerned, also, will the individual allow somebody else to get into the mouth? We're going to discuss some of that a little bit later, but I really just want to bring that up because, again, that's a really, really big part of the problem that we face. Many of our patients come into the office, we're able to go ahead and see them, we're able to clean their teeth, do their fillings, do whatever treatment they need. But we have a very, very large subset of our patients who cannot allow that. When they come in, they're really, really going to be much more resistant to care. They're going to have significant amounts of oral sensitivity, and that's going to make it very, very difficult to get past that defensiveness to go ahead and care for them. Now, when we get into the individual patient, and this is where we have to look at who is the individual, and it's very important not to create a cookie cutter type of mentality when we're talking about patient care. We can look at any patient, and honestly, everybody is different, and they all are going to present with very, very different challenges they have to overcome and that we have to overcome in terms of trying to go ahead and care for them and provide proper care. The mouth can be um, really very, very different. We may see some patients where if we take a look, we can see an open bite. We can see how the teeth are very, very badly broken down and they're going to collect a larger amount of tartar. We can see again that there are some patients where the mouth is going to be very, very difficult because of a tongue thrust going through. And it's going to also eventually lead to an open mouth posture that's eventually going to lead to issues with gum disease because the mouth stays open, the mouth gets dry, the gums become more infected. Some individuals can hardly open their mouth at all. This gentleman here, he was only able to open his mouth literally this wide. This was his maximum opening. Imagine trying to brush your teeth if you can't get a toothbrush into the mouth. We have to come up with some pretty creative ideas for that. How also am I going to treat his mouth if he develops cavities or he needs treatment if I can't get into the mouth? Again, this becomes a very, very difficult issue. We take a look at this picture over here, and we can't really see the lower part of the jaw. We can't really see the lower jaw so well, but you can see how small of an area there is back here, and how the tongue can barely, barely find any space to really fit down between these teeth. And you can see all of this yellow, all this tartar here. This individual, because of physical and intellectual disabilities, as a combination, was unable to brush their own teeth. This individual was unable to really, really allow anybody else to brush the teeth as well. And we had a lot of other issues, medical issues to deal with too, in terms of brushing those teeth. This person has a very, very poor airway. We have to be concerned. If we're brushing the teeth, will this person aspirate on the water that we're going to be brushing with on the toothpaste? So we have lots of things to deal with. And when we think about our patients, again, these are things that have to be thought about. You have to kind of think through. If you have any particular questions that you have about yourself or the person that you're caring for, that you're caring about, these are things that you need to bring up with a dentist to kind of try to find ways together to make things work. Now, again, many of our patients, if not all of our patients, are taking medications, and we're all taking medications this day and age. And one of the reasons why life expectancy has significantly risen for all populations, whether you're part of the disability community or not, whether it's developmental disability, a non-developmental disability, or you do not have a specific disability, one of the big reasons why life expectancy has improved is because of medications. There's no other way around it. Now, the problem is these medications, as good as they are and as important as they are for us, also come with some degrees of problems. And we need to be aware of what these problems are and how these problems are going to affect everything going on in the body and certainly with the mouth. So one of the first things that we see is the problem of xerostomia, which is a dry mouth. And there are hundreds and hundreds and hundreds of medications that one of the side effects that they cause, or the adverse side effects that they cause, is xerostomia or dry mouth. And that dry mouth is going to lead to lots of problems for our patients. If the mouth is really dry, it means that food is going to stick to the teeth. It's not going to come off as easily. It means that foods that are going to be eaten very often are going to have to be more of a pureed type of food. And that sort of diet, honestly, is the worst possible form of diet that you can imagine from a dental perspective. It sticks to the mouth. It's usually higher in carbohydrates, which when they break down to the sugars that can lead to cavities that are going to lead to bad gums, bad teeth. So overall, it's a real challenge. Xerostomia also, if you have a dry mouth, it means that your dentures are not necessarily going to be able to stay in your mouth as comfortably, which very often is going to mean that you can't wear dentures. And if you're not wearing dentures, again, that's going to overall affect the diet. So again, we see this is a real multifactorial problem, and all of these problems kind of tend to snowball, and one thing is going to affect the other. Now, another problem with medications is that many of them, specifically the ones that come in a liquid form, contain a very high amount of sugar. So someone is taking that drink of medication, right? They're drinking it down. Well, a lot of it's going to remain in the mouth. It's going to remain on the teeth and on the gums. And again, all of those carbohydrates, all of those sugars are going to cause problems within the mouth. So we need to be aware of the problems that medications cause. Medications also cause other problems. One of the very well-known problems that we see with medications, specifically affecting those with disabilities and more specifically affecting those with seizure disorders, is gingival hypertrophy. And this just means the overgrowth of the gum tissues. And you can see that very clearly here. You don't need to be a dentist or have any real dental experience to realize that those gums just shouldn't look like that. They're red, they're swollen, they're puffy, they're angry looking, they're easy bleeding. You can see how much tartar is building up within the teeth in those areas as well. Gingival hypertrophy is caused by a lot of different medications. Maybe the one that's most familiar to this audience is going to be Delantin. And it's certainly a medication that the physicians know causes problems, right? I'll call up and I'll speak with the physicians and say, hey, listen, one of the medications that our patient is on is causing this gingival hypertrophy. The physicians know about it, but very often the problem is this is the medication that works. So we can't get around that. That means that we need to be much more aware of the problem. We need to work harder at keeping the mouth clean. We need to work harder at getting our patients to understand the importance of this and understand how critical it is to take oral hygiene seriously. And another concern that we see with medications as well is GERD, right? Many of our patients have significant amounts of indigestion. When we have those stomach acids rising up from the stomach and rising up into the mouth, those stomach acids are going to affect the teeth. They're going to wear down the teeth. They're going to erode the gums. They're going to cause problems in the trachea as well, the esophagus as well. So we need to be aware of GERD. We'll see in a couple of slides down, we'll see a little bit of what GERD looks like in the mouth. And dentists, fortunately, are very aware of GERD and will be very quick to point it out and, direct you to a doctor to, get that situation under control. So when we talk about diet is also a really big deal. When I was back in dental school, again, 30 some odd years ago, we didn't work closely with dietitians, but nowadays, at the stage of the game, the dental students really are getting a very good education in how dentistry and nutrition really, are confluent together, and they really make a difference in how things work together. We mentioned if our patients are on a puree diet, how bad it is for the mouth. And you can see that, from how things look in that top left picture over there. And again, you can see how red and raw and angry looking those gums are. Many patients that we have are patients that are tube fed. And a patient's tube fed, all the nutrition is bypassing the mouth altogether. So we may not necessarily have to worry too much about cavities, but we've got to worry a lot about the gums. If we take a look at the picture on the bottom left of your screen right now, you can see all of that tartar buildup. And believe me, we have patients where the amount of tartar buildup is much, 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 much worse than even this picture. And this is a pretty dramatic picture, to be perfectly honest with you. It's very difficult to get this off. Once the tartar builds up like this, it doesn't just toothbrush off. It's got to be professionally cleaned off if it has to come off at all. And for many of our patients, they're being tube fed because they have aspiration issues. And so that means that trying to do a cleaning for them is going to be much more dangerous. In many cases, it's going to be life-threatening to go ahead and do those cleanings in an office setting. Many of those patients have to go to the operating room and be put under general anesthesia in order to be cared for. So again, this can be really, really problematic. So diet, again, absolutely affects our patient population. The picture we see on the right is the one I was kind of talking about before when we were mentioning GERD. You can see how eroded away those teeth are. You can see the silver fillings kind of sticking up out of the tooth, right? If we take a look over here in particular. And this is what GERD looks like. This is the way the teeth are basically worn down. Over the course of time, these teeth can eventually get worn down to the point that they really, really are worn down flat, even with the gums. Um, Very often these teeth don't hurt. Sometimes the teeth do hurt. So we do need to be aware of that as well. But again, oral hygiene is a significant challenge. There are lots of reasons for it. There are lots of potential complications that we, our patients, and the caregivers who are involved with them have to really, really care for if we're going to go ahead and make things better. So the last part of this talk really is how we can make a difference in oral health. And we all can. And it's very, very important that we work as a team. Dentistry is not the sort of field where we do the work on our own. It's something where it involves our patients, it involves caregivers. It really does, honestly, like the saying goes, it takes a village to keep the oral health really, really healthy for our patients. It's a really, really big deal. So let's talk a little bit about a couple of things. So first of all, and this is something where it's on you. You think broadly, the audience are listening to this right now. It's on you. When you go to the dentist, make sure that you have with you all of the information that your dentist is going to need in order to care for you properly. I've been doing this again for well over 30 years. And as much as I talk about this, as much as I mention these issues to patients over and over and over and over again, honestly, it's a big frustration because this is something that really limits my ability to care for my patient. I need information. If I don't have the information that I need to properly care for you, you're not going to get the care that you need. And it's important that you bring it with you when you come to see me or any other dentist. First of all, know the medical history. It should be a thorough medical history. If possible, know the dates of any procedures or surgeries or diagnoses. Know what the conditions are. Know what's going on about each condition, right? A person has diabetes, but the question is it type 1 diabetes or is it type 2 diabetes? What is your A1C? Do you check your blood sugar on a regular basis? If you know these numbers, if you know these things, bring that stuff to the dentist with you. Make sure that your dentist knows these things. We all carry cell phones with us now. It's very, very easy to put this information into your note appliance, into your note app, onto your phone. It's easy enough to take pictures of the bottles of medications. This way you always have this information. Should you need to go to the emergency room? Should you go to the hospital? Should you have to go to see another doctor who doesn't necessarily have access to this information? Should you go to your dentist? We need this information. And it can save your life, and certainly, at the very, very least, it can make sure that we can treat you better. It's very important to have a list of medications that you're taking with you. If you're tapering off of medications, advise the dentist of that. If you're going to be switching to new medications, if you're going to be trialing medications or being involved in a drug trial, it's important that I know that as well. It's really, really important. Aside from just the prescription medications, what are you taking over the counter? Are you taking vitamins? Is it a multivitamin? Is it vitamin A, B, C, D? Which vitamin is it, right? What other supplements are you taking? A lot of people are taking protein powders. Well, we need to know those things as well. What herbal medications is a person taking? Are you taking ginkgo, ginger, ginseng? Well, those medications influence bleeding. And so if you're taking something like that, specifically those three with the G's, those can cause significant bleeding if I'm going to go ahead and do an extraction. So I, again, need to know that beforehand before we can properly plan how we're going to best go ahead and take care of you. So we need to know what the medications are that you're taking, both prescription medications and non-prescription medications. And honestly, always tell your doctors this. Don't assume, oh, he's a dentist, he doesn't need to know this. It's not really important. Well, it is important, and we really do need to know it. So please bring that with you. And again, you can always just take pictures of the bottles of medication, or you can list them in a note app and just show it to the dentist or the physician when you go for your appointments. We need to know a list of all of the allergies and bad drug reactions that you've ever had. Again, that's really important. Dentistry, honestly, one of the reasons I went into dentistry is because, it's not that hard to kill somebody. It's not that easy, rather, to kill somebody as a dentist. We don't have a lot of deaths, thank God, knock wood, for our patients in dentistry broadly overall. But, one of the ways in which our patients can get very, very seriously hurt is through allergic reactions. So we need to know what you're allergic to. What medications should I not prescribe? Because maybe you're not allergic, but they really, really have really bad adverse effects on your GI system, right? So I really want to know what's going on. What foods, what medications, are you latex allergic? Latex is not something that's used very, very commonly in dentistry anymore or in medicine broadly anymore, but some things that are used still do have some degree of latex, and we need to know if latex is an allergic concern. What labs do you have? Did you have any recent blood work that was done? If so, if you've got the results, bring them. If you access them through a MyChart or some sort of electronic health record system, make sure that you're able to get access to that so we can go ahead and we can take a look at what those results are. Do you have recent images? Maybe those images came as x-rays from another dentist, or maybe it was a chest x-ray, or maybe some other CTs or MRI scans. Again, bring those in. Maybe those are things that we want to look at, or at least we should know they exist so we can go ahead and talk about them. Now, one thing that really does fall into this, maybe it's not so much a quote unquote medical issue, but something that is just as important, if not more important in a lot of respects, is behavioral considerations. I don't like going to the dentist. I'm nervous about going to the dentist, to be perfectly honest with you. I really just don't like it. It's important that I know if somebody else doesn't want to go to the dentist, if they don't like going to the dentist. Is there fear of dentistry? Is there phobia of dentistry? What makes a person comfortable? What makes you uncomfortable? Does dark light help you if you're in like a darkened room? Does bright light make you feel a little bit more comfortable? Does a weighted vest or a weighted blanket make you feel more comfortable? All of these behavioral considerations are a big, big deal, and we should know about any behavioral considerations that you have going on when you come in as well. Also, any dental referrals. If you're referred to a dentist, if you're referred specifically to me by somebody else, try to bring the referral with you. It'll give me some information that maybe the last doctor wanted to transmit to me that maybe you're not as familiar with yourself from the conversation you had with the last doctor. So again, having all this stuff with you really, really is critical to allowing us to go ahead and provide that care in the manner that's best. Now, from the dentist side, and if there are any dentists out there, any dental professionals, dental hygienists, dental assistants, even front desk staff, we need to think a little bit about how, as a dental professional, we're going to intervene specifically with our population of patients and the population that we're talking about here today. Very often, the recall visit or the recare visit is going to be much, much more important and really much more critical for our patients than it is for the population at large. If my patient has no disability, has no problems with their mouth, no problems with their teeth, honestly, seeing them every 6 months may be more than I even need to see them. Maybe I really only need to see them once a year. But the reality is, for many of our patients, it's more than every 6 months. Many of our patients, we want to see our patients every 3 months, sometimes even every 2 months. So we need to think about all of this, and we need to think about what the proper recall system is for our patients. And it's important for an individual as a patient or the caregiver to make sure that you're keeping up with those recalls, right? Make sure that if you don't get a call from the office saying, hey, your appointment is due, let's set up an appointment, make sure that you're giving a call to the dental office to get the appointment. We need to make sure that we're getting a proper frequency of x-rays. And again, some people are scared of x-rays, but in the current age, in our modern day and age, we're using digital x-rays. We are certainly using them exclusively. Pretty much every dental practice is using digital x-rays. The amount of radiation is slim to none. I mean, it really, really is. There's no concern over radiation whatsoever. And the need to get those x-rays far, far, far outweighs any potential risk. So as a dentist, if you need x-rays, get the x-rays. As a patient, if you're concerned about getting x-rays and you're going to be resistant to them, don't worry. It's going to be something that's really going to be very, very beneficial for you. Sometimes we can't get the little x-rays that go into the mouth because a person may have real dental sensitivity and oral defensiveness. Sometimes a panoramic x-ray, which goes around the outside of the head without the need for anything in the mouth, may be the way to go as well. Will it give me all the information I get from those little x-rays inside the mouth? No, it won't. But it very often will give me a lot of information that I wouldn't otherwise have if I didn't at least have that. One thing that a lot of dentists on the outside do, especially those who are not really as conversant with dealing with patients with disabilities broadly or with developmental disabilities more specifically, is they tend to kind of watch and wait. And they tend to hope that the problems stay well controlled, and in some cases they will. But the reality is that in the vast, vast, vast majority of cases, a watch and wait approach just means that cavities are going to get worse. You know, if you have a cold, you go ahead, take some chicken soup, wait a week, and that cold's going to go away. But with dental cavities, the reality is those cavities will continue to get worse. Gum disease will continue to get worse. The oral hygiene, the oral health will continue to get worse if it's not cared for. So it's very, very important that we go ahead and we are a bit more aggressive in dealing with those issues. And as a dentist, make sure that you've got referral sources available. If I see a patient and that patient has GERD or I'm seeing GERD in the mouth or indications of it, I want to have a GI doctor I can refer my patient to. I want to have a neurologist that I can refer my patient to if my patient needs a neurologist or a pulmonologist or a cardiologist. I want to make sure that there are dental professionals outside of my specialty. I'm a general dentist. I want to know, is there a periodontist? Is there an oral surgeon, an endodontist out there who can care for my patients? So find these people, keep them, on your Rolodex or whatever electronic form of that you use nowadays. Also, fluoride supplementation is very, very, very important. Nowadays, especially with the political climate that we're involved in now, there are a lot of attacks on fluoride. Here in New Jersey, fluoride is not really in the water except in very, very, very few towns spread throughout the state of New Jersey. I grew up in New York, and I did my initial training, my residency training, and my fellowship training in New York. I spent my first couple of years working as a dentist in New York. When I was working with my populations, we did a lot of fillings on a lot of patients in New York. When I finally moved to New Jersey, the biggest difference was, yes, we saw the same amount of decay, we saw the same amount of really, really bad problems, but we saw them being much, much worse and far more quickly accelerated. Instead of doing all those fillings, now we were taking teeth out. And a lot of this is due to missing fluoride. So fluoride in toothpaste is critical, critical. Fluoride in water is not going to happen. You're not going to get enough fluoride from the fluoridated waters that you drink as bottled water. So it's got to come from toothpaste. It may come from vitamin supplementation, but it's very important that you're getting it. It's important to get fluoride treatments as well from the dentist or hygienist that's going to be cleaning your teeth as well when that gets done on a regular basis. So fluoride is really critical. If you're concerned about fluoride, again, don't be. It is probably one of the greatest public health innovations of the 20th century and 21st century, certainly. It's something that is a true, true necessity. It's been studied and accepted by every medical and dental society of any value and any note, not just within the United States, but around the world. So again, fluoride is a really, really important thing. Now, just a couple of things in terms of toothbrushing tips and tricks, to kind of make life easier. Again, many people don't like to brush their teeth. They don't want to brush their teeth. They're not comfortable brushing their teeth. It may be difficult as a caregiver if you're brushing someone else's teeth as well. So don't necessarily do it in front of the mirror at the bathroom. We're all trained to go to the bathroom, stand by the sink, by the mirror, and brush our teeth. That's the way I do it, right? But the reality is that's not for everybody. For some people, well, brushing the teeth in the kitchen, maybe that works better. You're more comfortable in the kitchen. Maybe it's best to do it while sitting on the couch, while you're watching TV during the, in the morning and at night. That may be better for some people. For a lot of our patients, brushing teeth while in the shower or in the bathtub is really much better as well. The shower or the bath, you've got all that water going on. It's a soothing environment. There's a lot more going on from a sensory perspective. And for a lot of patients, that may be the best way to brush teeth. So again, don't be tied to the bathroom sink. Basically, it can be done wherever it's going to work. And, the real important thing to realize about home oral health care, do what works. Find what works, think outside the box, speak with your dentist, dental hygienist, try to find ways to make it work as best as you possibly can. But brushing in different places, brushing at different times may be the best thing for the individual that you're working with. Also, how is a person positioned? Again, some people can't stand at the sink or sit in a wheelchair at the sink, right? Maybe they can sit, maybe they're in a wheelchair. And the question is, how do you go ahead and treat them? Well, go ahead, instead of trying to brush the teeth from coming in from the front, go to the back. Go to the back. So stand in the back, support the head, and you can brush the teeth more easily that way. It's going to be more easy for the caregiver. It's going to be more easy for the patient. Same thing as well in terms of if the person is on a beanbag chair or laying in bed. It might be much, much easier to brush the teeth in bed as well, or even sometimes laying on the floor. If we take a look at all of these pictures, all these diagrams here, the thing that you really, really see is that for the most part in general, the caregiver is approaching this from the back or from the side, which gives you much more control and makes it much more easy to brush the teeth, both for you and the person whose teeth are getting brushed. So it's very important to do it that way. And that degree of control is important. And it'll also make the patient feel much more comfortable. So find whatever position is going to best work and use it. If there are two caregivers that can assist in making the toothbrushing better, by all means, it may be much better. Somebody may help to hold the mouth and the head while the other person holds a toothbrush. So again, do what works. Use a timer when you're brushing teeth. This is a real big issue. Now, some of your patients may be in a situation where they'll only tolerate 30 seconds, if that, of toothbrushing. But for many patients, it may be significantly less than that. Apologize for the phone. Um, but ideally, teeth should be brushed for about 2 minutes. Keep that brush in the mouth moving for about 2 minutes. You can utilize any type of timer you want. You can go ahead and find a song that plays for about 2 minutes that somebody likes on the phone and play that during toothbrushing for about those 2 minutes. Use whatever you can to encourage toothbrushing for those 2 minutes. And the reality is 2 minutes lasts longer than you think. So if you think you've been brushing for 2 minutes, maybe you haven't. So using a timer may help you brush your teeth much better yourself. One of the other things that's very important is don't be scared. If you see bleeding from the gums around the teeth, all that means is the gums have to be brushed more. It means that there's inflammation in the mouth. It's very seldom that you're going to find that you're brushing the teeth so hard that you're damaging the gums. You should be brushing with a soft toothbrush, only a soft toothbrush. Never, ever use anything else other than a soft toothbrush, whether it's a battery powered one, an electrical one, or a manual toothbrush, a soft bristled brush, and it won't damage the gums. It won't cause the bleeding. If there's bleeding going on from the gums, that means that there's inflammation. The only cure for inflammation in the mouth is better toothbrushing and more toothbrushing. So you've got to make sure that you're getting in there and doing it. And we'll get to just a little bit about mouth rinses as well. Maybe you need to get professional help. Something that I find that can be very helpful for a lot of individuals, especially with oral defensiveness, is the need to find an occupational or physical therapist or a speech pathologist to help get that person past that oral defensiveness. Again, if a person can't brush their teeth themselves and is never going to be able to brush their teeth themselves, I'm not looking to push them. What I'm looking for is that that individual is going to let mom or dad or the caregiver or at least the dentist get into the mouth to clean the teeth and to get stuff done. So find a therapist that's working with you, either at school or at a program, or ask for the recommendation from the physician that you're working with to get a therapist, get the help that you need to help make that oral defensiveness decrease. It may take months, it may take years, it may never happen. But the reality is, if it does, it can be very beneficial for you. Very quickly, toothbrush, whatever works. Again, like I said, a toothbrush should be a soft bristle brush. It can be battery powered, it can be electrical, it can be manual. For patients and individuals with autism specifically, a lot of times The power brushes don't really work so well because the vibrations, because the sound really set off a sensory overload for those individuals. So manual brush may be the best, but try them. Don't go out and buy an expensive system. Go out and buy, a $6 spin brush and try that. If it doesn't work, you've wasted $6 instead of spending 60 or 100 or more on an expensive system. Again, with toothpaste, it has to have fluoride in it. Don't go for the natural toothpaste without fluoride because you're only hurting yourself. There are some of the natural toothpaste, for example, Tom's of Maine is a natural toothpaste line. They have one of their line of toothpaste with fluoride. So if you like Tom's of Maine, find their fluoridated toothpaste. But fluoride is critical to maintaining oral health, especially in New Jersey where we don't have fluoride in the water. Flossing can be a real challenge. The best way of flossing is not to use the string the way we were all taught how to floss, but maybe something like this Listerine Access flosser that you can see here. It's basically a long-handled, almost like a toothbrush handle, and there are little bows of floss that clip into this that you replace every time. And you can buy the starter kit, and then you can buy refills on the bows of floss. This is phenomenal, especially not just for someone flossing their own teeth, but even more so for somebody flossing somebody else's teeth. Really, 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 really good thing. You can get these in Walmart, CVS, Walgreens, on Amazon, wherever. So you can look for them. And oral rinses, Listerine and Listerine analogs work really, really well. Mouthwash is a really helpful part of the oral hygiene package. A lot of people can't hold the mouthwash in their mouth. They'll tend to either swallow it or just spit it right out. So if that doesn't work that way, then after toothbrushing, take a gauze pad, take a cotton roll, take a toothette, dip it into the mouthwash, rub it on the gums where the gum meets the tooth, and at that interface, rub it on and then leave it there. Nothing to eat, nothing to drink for an hour afterwards. Let it soak into the gums. Yes, it's going to be of some help. And again, one of the biggest tips I give people is I encourage water after all oral intake. After breakfast, water. After lunch, water. After dinner, water. After snacks, water. And ideally, if you can swish and spit, fantastic. If not, even just drinking down the water can be very, very helpful. And last thing, just a couple of things that may be helpful to you. Touthettes are something that you probably are very familiar with. The open wide mouth prop is a really, really neat little appliance. And I have one here. This is something that can go into the mouth to help to keep the mouth open while you're trying to toothbrush. If the mouth is open on the left side, on the right side with this, you can brush on the left side and then switch around. So these are really, really very helpful. They come in the regular size, they come in the thicker size. They're extraordinarily, extraordinarily helpful appliances to use. Again, you can buy them through Amazon or you can buy them through the company itself. Also, there's a device called the Plaque Vac and the Rescue Vac, which basically is a toothbrush with a hole in it that runs all the way through the handle, and you combine it with the Rescue Vac, which is a handheld and hand-activated suction device. So for individuals who have a hard time with saliva and a hard time with any toothpaste or anything that's going into the mouth, this can really, really make everybody's life a whole lot easier and a whole lot safer. So this is something really important that can really be very helpful. And again, you can buy these online. You can buy them through the company. I think if you look at the whole package overall, I think it's about $125 for the two of them together. The toothbrushes are replaceable. Again, you can go ahead and you can buy the toothbrushes in bulk as well if you want to. The very, very last thing I want to talk about is just a quick case presentation just to understand how important things are as a person gets older, because very often we don't necessarily think about that. Patient of mine presented at the age of 32 with Down syndrome. Moderate intellectual disability, overall medically stable, nothing really exciting going on. Her oral health status was really very, very good. Her oral hygiene was really very good. Everything was fine. I followed her over the course of the years. As she got older, and again, I've been here at the dental school for about 24 years now. At the age of 53, all of a sudden things are different. Dementia has set in. A diagnosis of Alzheimer's dementia came about 5 years before this point in time, and the dementia has deepened. There was a diagnosis of diabetes as well that set in. This patient is now on multiple medications. The oral health status is worsening overall, just as a result of everything that we had discussed before. And overall, the periodontal health is declining as well. Now, all of a sudden, whereas we were able to keep the oral health really, really good, keep the teeth really good in younger age, now all of a sudden things are changing. So we need to be aware of the way things change over the course of time. I know I probably went on longer than I meant to, but there's a lot of good information there that hopefully is going to be helpful for you. If there are any questions, I'd be more than happy to take them. Thank you very, very much for your attention.
That was amazing. Thank you so much. We actually do have some questions. Um, our first question was if you could speak about the differing indications for general anesthesia versus other forms of anesthesia and pain control for our population.
So that's a very big question. We use general anesthesia for our patients who require care, for example, fillings, extractions, even cleanings, sometimes even just exams and x-rays. Um, those patients, we really use it for two reasons. One is either behaviorally, the patient is unable to tolerate care awake, or number two, medically. Again, very often the biggest problem that we see where we need to utilize general anesthesia is there's some sort of respiratory problem. So, for example, best picture I can give you is a picture of an individual with CP in a wheelchair, spastic quadriplegia, who has poor control of their airway, poor ability to control any limb functions, to control the head, the neck. That's an individual who very, very often is going to need to be seen in the operating room. We prefer general anesthesia to IV sedation for a whole lot of reasons, not the least of which is that with general anesthesia, the person is under the most control possible from the perspective of the airway. So, really, in a lot of respects, even though it seems like it's a more extreme form of care, it's actually the safest. And it's actually the most conservative approach that we can take outside of having the patient awake in a dental chair. Aside from that, um, it's a very, very big question. So if there are specifics, I guess I could get into that, but that kind of gives you something of an answer, I think.
Excellent. And then the next question, can you please speak about approaches to bruxism? I think I'm saying that correctly. That is damaging to the teeth, that is damaging the teeth for an adult patient.
Bruxism is a really, really, really difficult problem, and it occurs in individuals with disabilities, without disabilities, with developmental versus non-developmental disabilities. It's a big problem in general. Um, there's really there are only a couple of ways in which you can resolve bruxism. If a person has good cognitive function and good ability to deal with bruxism from a neurological perspective, you can try a psychological approach, basically reducing stresses, basically meditation, biofeedback. These are techniques that really, really can help with bruxism for some people. Unfortunately, for a lot of my patients, that's not going to be a reality. The other way of looking at treating bruxism is by using a mouth guard, by using an appliance. These mouth guards can be bought in a sporting goods store, and they can be molded with hot water into the mouth, so they're available over the counter, or they can be made professionally. They're used at night because that's very often when bruxism really, really hits. For many patients, many individuals, they're used all day long. They're taken out during eating, obviously, and taken out to clean, but they're used during the day. Bruxism is really damaging because grinding those teeth together up and down or continually clenching the teeth is going to break down the teeth. And again, that's going to wear the teeth down, sometimes to the gum line. Again, sometimes it's going to cause pain, sometimes it's not going to cause pain, similar to when we were talking about GERD earlier. But yeah, it's a real problem. Now, the problem becomes for those individuals who are not able to wear a mouth guard and for whom any sort of psychological treatment is not effective. There really is no other way to deal with bruxism. Unfortunately, for those individuals, they're going to be grinding their teeth. And, for those of you that, have experienced it, that grinding can be very, very loud. It can truly can be very damaging. One thing to take a little bit of solace from is that as the teeth are ground down over the course of time, the nerve inside the tooth tends to kind of, distance itself from the surface of the tooth as well. So what tends to happen is you don't actually have pain in a tooth as a person is grinding, or at least it generally doesn't happen. So that's a good thing. Bruxism is a tough one. And especially for my patient population, unfortunately, for many of our patients, there's not much you can do about it. Bad
Thank
news.
you.
Sorry.
And then we have my 67-year-old son had 3 consecutive bridges to replace tooth loss in his lower right jaw that he lost. I'm sure they were painful for him. I'm afraid for him to have implants because of the danger of infection. He is healthy and only takes meds for BP and cholesterol. He was born with a port wine stain on his cheek that goes through to his gum, and most dentists tell me that doesn't cause any problems. Are implants safe? I hate to think of him having dentures, which he might lose and will really affect his quality of life. Thank you.
So I'm going to address the specific concern here, but also just kind of speak broadly about implants. Implants have been in use now within dentistry for probably around 50 years, to be perfectly honest, if you go back to the earliest use of implants. They're very, 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 very well studied. Implants that are placed well, and when they're placed in patients who can tolerate the implants and for whom those implants are appropriate, they'll last a very, very long time, and they're very, very safe, and they're very good for patients. Very easy to say that. The big problem is that if the oral hygiene is not good, then the implant, which is basically a screw into the bone, will not be able to heal effectively. It will become infected, and the infection will affect the gums around the implant, and it'll affect the bone that's holding that implant in place. The implant will fail, it'll come out, and the bone will become infected, which can affect the other teeth next to that implant as well. So it's one of those situations where it's a real important thing that the dentist evaluate the situation very carefully, and that whoever the caregiver is, I guess this is mom or dad talking, um, make sure that the dentist knows everything about the patient in terms of their proper oral hygiene and be very upfront and very honest about it. Implants work well, but they're not for everybody. Now, in terms of the safety of placing an implant, again, that's going to be very, very dependent on a lot of things. The port wine stain is it's a vascular lesion, and so placing the implant can become somewhat of a of a tricky situation. Implants very often are placed either by periodontists or by oral surgeons. Before they go ahead and place those implants, they're going to really, really want to get into the medical history. They may want to get some medical consultations as well to make sure that that's going to be appropriate. The implants may be placed in a dental office setting, or they may be placed in the operating room setting, again, depending on the individual patient. So the goal always is to do things in as safe of a modality as possible. Best question to ever ask somebody who places implants is, how many have you done? You want someone who's done a lot of implants. You don't want somebody who's only done a couple, especially if it's a more complicated individual who's a little bit older, especially where you've got disability that you've got to deal with too. So I hope that kind of answers that question.
And then Paul would like to know if you are seeing new patients.
Uh, that's the question I kind of hope people wouldn't answer much, wouldn't ask much. Yes, we're seeing new patients. Yes, we're seeing new patients. We are not stopping new patients from coming in. We did stop for a small period of time, and now we're back to seeing new patients. The big problem is that our waiting list is very, very long. For those patients who need to be seen in an operating room setting, our OR waiting list is probably over 3 years. And those patients who need more immediate care, we expedite their care. And very often I'll tell the individual, listen, we'll get to you, but it's probably going to be about a year before we can do that. I'm not happy with that information. I'm not happy saying that, but that's just what the reality is. Getting OR time is really, really, really hard. And it's a lot easier in New Jersey than it is in a lot of other states. If you look at other hospitals, if you look at other programs, a lot of other dentists who go into the hospital, their waiting lists are going to be 2 to 3 years as well. So it's really, really difficult. So if you need the OR, it's going to take time. If there's an emergency, if there is a more expedited need for care, we'll do the best we can to work on that, but it's going to be hard. As far as seeing new patients who come into our clinic setting, yes, again, we'll see new patients. My particular patient population right now, I'm probably close to 6 months out. So if you call up and you want an appointment specifically with me, it's probably going to be about 6 months. The other doctors who work in our program as well, again, it's probably close to that. It's between 4 to 6 months for many of our patients. So yeah, it's pretty tough. And one of the big problems also is it's going to be very, very difficult, as I'm sure many of you know out there. It's going to be very difficult to find dentists willing to treat patients with disabilities, especially if it's a more significant disability, if you're further on the more extreme end of the spectrum. So it does become difficult, but yeah, that's kind of where we are right now. Again, not good news, but it's an honest assessment of where we are.
And then do you ever recommend botulinum toxin to address bruxism?
Yes, and it does work in some cases. It does work in some cases. It also works very well for patients who tend to drool a great deal. In those cases, what I'll do is I'll refer patients to an oral surgeon, and the oral surgeon will go ahead and and deal with it. One of the downsides to it is that the use of of Botox, really, it has to be injected and re-injected every so often for the most part. And over the course of time, that can become problematic. But yeah, it can work. It can work. It's a varied success in varied individuals, but I have seen good success in some people. So it's certainly something worth talking about with your dentist. And, the dentist either they may do it themselves. We don't do it ourselves. What I'll do is I'll refer to our oral surgeons and have them assess the situation and see if they feel it's best to be done. But yes, it can work effectively.
And Paul would also like to know if you sedate in your office.
We use oral anxiolytics to go ahead and kind of relax an individual, something along the lines of like a Valium, but we don't do anything much more significant than that as far as sedation. We will sometimes use nitrous oxide or laughing gas, which goes over the nose. Again, the biggest issue is, can an individual, use the laughing gas or not, right? The biggest contraindication, the biggest negative about laughing gas is if the individual can't tolerate the mask. Many people are very claustrophobic. They can't tolerate those masks, so can't be used. But we do use nitrous oxide. We will use oral anxiolytics. So basically, it's a low grade of oral sedation. Beyond that, we do not. If a person needs IV sedation, if they're a candidate for it, we would refer them to our oral surgeons if they can go ahead and do it if they feel comfortable. Otherwise, we'll go into the OR and do general anesthesia. What I will tell you, again, I've been doing this for a very, very long time, and I've seen a lot with my patients and with other people's patients. My very, very, very strong belief is that general anesthesia is a much safer modality of care for a lot of reasons than IV sedation. So I would strongly, strongly encourage you to think along those lines. If it's a question of getting out one tooth here and there or something along those lines, an oral surgeon may feel comfortable doing it in the office setting with IV sedation. But the truth of the matter is, very often they're going to say their concern is that the airway is not safe or the IV access is not going to be safe. So they would may prefer to do it in a hospital as well. So long answer to a short question. But no, we don't do IV sedation in our practice, but we will use others.
We have one final question. My daughter has autism and gives me a hard time brushing the inside of her teeth and the inside of the molars. She also swallows the toothpaste and never learned how to spit out the toothpaste. Is it harmful for her to be swallowing the toothpaste? Also, how can I get her to let me brush the back molars on the inside?
Really good questions. Number one, swallowing toothpaste is not going to cause a problem. In order to really have any real negative effect of toothpaste, you'd pretty much have to take a whole tube of toothpaste and swallow it down. And even with that, you'd only get a tummy ache. It doesn't really, really cause problems. Remember, toothpaste, mouth rinses, these items are developed for use in the mouth. And it's known that some aspects of them, some small parts are going to be swallowed, even if you're not trying to. Some of it's going to be swallowed, by anybody over the course of time. So no, it's not going to cause a problem. So you can rest assured that's not a concern. If there were no airway issues about swallowing something and possibly aspirating it back, then you really don't have to worry about that from that perspective. So don't worry about toothpaste. And again, like I said, I would strongly encourage a fluoride toothpaste. Again, even if that's swallowed, the small amounts of fluoride in the toothpaste are not going to cause any problems at all. So don't be concerned about it. Now, again, to get into the mouth, if your daughter has a hard time, opening and allowing you in, again, the use of something like, this stick here, the open wide mouth prop, is really, really very beneficial. It goes into the mouth, and if she tends to bite down on it, it's still going to allow you good access to the inside of the mouth. If you want to do something that's a really, really low tech sort of way, you can take a washcloth, not a paper towel, but a washcloth, roll it up, soak it in water, wring it out, roll it up and fold it over. You can put that in the mouth on one side while your daughter is kind of chomping down um, on that washcloth. Again, the mouth will be open enough for you to be able to get to the inside. So there are ways of doing it. You want to try to get something in the mouth to kind of keep the mouth open. Always be very careful what you're putting in the mouth. Never use something that can potentially be broken or bitten off in the mouth. That's why these open wide props are good. Basically, the open wide mouth prop is essentially a very, 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 very thick tongue depressor that's encased in styrene plastic. So it's very safe. It can't really be bitten apart. You can throw it in the washing machine, in the dishwasher to use or something like that, and it'll last for a long time. So yes, you want something that's really kind of professional grade because you don't want to risk something being bitten off.
Excellent. And then we've got some thank yous and a personal thank you from us too. This was so informative and so fantastic. And we really appreciate you coming and talking about this with us today. Thank you so much.
Very much. I appreciate it.
And I
So
want to
let's
thank
next week.
everybody for coming as well and for attending. And I hope everybody has a fantastic rest of your day. If you think of any of the any other questions, please feel free to reach out to Dr. Spivack. His email is right on the screen. And again, thank you all so much. I hope you have a fantastic day.
Take care, everybody. Thank you again.